Good morning. My name is Kevin Glassman, and on behalf of the Board of Directors of ALS United Greater New York, and as a member of the organization's Care Services Committee, it's my pleasure to welcome you to the 5th Annual Education and Resource Summit, Navigating the ALS Journey. Most of the board members and staff here at ALS United have a very personal relationship with ALS, having had family members or friends diagnosed with ALS. So at our core, we are passionate about finding a cure and helping patients and families that are navigating this very difficult road. Over the next 2 days, you'll have the opportunity to take part in numerous sessions and conversations that span a wide variety of topics related to ALS, everything from research and clinical trials, palliative care, personal experiences on living with ALS, to managing nutrition, and a great deal more. In this time of threats to funding, we at ALS United Greater New York continue to provide all services and programs to our community at no cost. We're committed to you, our constituents, and pledge to maintain our support, especially now that resources may be scarce. Our mission guides us as we raise awareness, educate, support, research, and advocate for much-needed legislation. Together with our 9 partner clinics, our Care Services Coordinator, Equipment Loan Department, Assistive Technology Specialists, and Grants Coordinator, we are all devoted to working every day to ensure that the families we serve are heard, assisted, and guided. We're very proud of our collaborations with others in the ALS space, many of whom will be among the esteemed presenters in the next 2 days. Together, we're making impactful strides towards a cure and remain committed to funding the most promising research advancements. This research pipeline has grown exponentially, providing us with more hope today than ever before. We at ALS United Greater New York are here for you and to support you as you navigate this journey. Together, we are relentless in our fight against ALS, and together we will end ALS. Thank you again for joining us for the next 2 days.
To the Education and Resource Summit. My name is Cherise Santos, and I'm a Care Services Coordinator in New Jersey for ALS United Greater New York. Before I introduce our speaker, I would like to spotlight the Hackensack Meridian Health ALS Clinic. The clinic is going on its 5th year and is located in Paramus, New Jersey. There are 7 disciplines, including 2 neurologists. Included in the disciplines is respiratory therapy, which leads me to today's speaker. AJ Polster is a respiratory therapist with Millennium Respiratory Services. He has worked with the neuromuscular community since 2008. Thank you, AJ. Please post any of your questions in the Q&A section at the bottom, and we will answer them at the end. AJ, you can share your screen now. Thank you for doing this for us.
Great, thank you, Cherise. One second. Okay, great. Again, my name is AJ Polster. I work for Millennium Respiratory Services, and I do the clinics at the Paramus Hackensack ALS clinic. And I work there closely with Cherise and multidisciplinary team of other clinicians to help evaluate and care for the ALS patient community. During our respiratory evaluations, there was a lot of different evaluations that we do. For respiratory, we do vital capacity, we do peak cough flow, we do heart rate, oxygen saturation, and carbon dioxide, specifically end-tidal carbon dioxide, which is measured at the nose as compared to either transcutaneous or like an ABG, a blood jet. We also calculate the respiratory rate. So with these parameters, we can get a good idea of and track the respiratory status for our patients from visit to visit, which usually is about every 3 months or sooner if needed. So with the vital capacity, to start with, we do a sitting vital capacity. So essentially, our patients will sit in an upright position. We'll have them blow into the right respirometer, and we'll get an accurate depiction of how strong their respiratory muscles are when they do the breathing test. Then we'll lay our patients down flat, and then we'll do the same breathing test to get an idea of how well the respiratory muscles are while they're letting down. So we take those averages and then we divide them into an average of height and age for a demographic of people, of the height and age, and we divide what they blew into that predicted, and that predicted that average is either it's usually worldwide. So basically age and height, and we'll divide those into each other, and we'll get a depiction of where they are. 80 to 100% is considered normal. If they drop down from month to month, then we know that we're going to have to intervene with respiratory care. That could be ventilation, cough therapy, stuff like that. And we'll go into that a little bit in detail later on. So then we go into a peak cough flow. This is a flow meter that will measure how effective a person's cough is. So we get an accurate number there, and then we can either prescribe the cough therapy based on how low those flows are, and then we can intervene with cough machines, insufflation, exsufflation devices. More specifically, it would be different brands, and we'll go into that again. Then with the end-tidal carbon dioxide, what we're essentially going to measure is if carbon dioxide is built up in our patients, we want to get rid of that.
AJ, excuse me 1 second. I'm sorry to interrupt you. Could you move closer to the computer, if possible?
Is that better?
That is better. It was a little hard to hear you. Thank you.
Thank you. I appreciate that. So with the end-tidal carbon dioxide, we want to specifically focus in on getting rid of the carbon dioxide built up in our patients. So when they're hypoventilating or underventilating, we want to make sure that we can, basically give them a nice deep breath, and then we can just exhale all of that out. And that, again, will be done with the ventilation, and then that'll work inverse with the oxygen. So if the oxygen's low, the carbon dioxide is high, we'll basically do the ventilation, and then we'll bring the oxygen up, and then we'll kind of kick the carbon dioxide out. So moving forward, based on the evaluations, again, we'll get the referrals, and recommendations are made to the doctor. So we'll discuss to the physician what we feel the need is for the care of the patient at that time. So maybe it's just that they need some help with their cough, and they're kind of okay for ventilation. So we just say, okay, maybe just do a cough and maybe suction machine if they're hypersalivating, and go from there. So once the physician gets those recommendations, they can put together a narrative of what needs to be done with the notes and why we're prescribing it. And based on all of that information, that's sent over to our offices or other DME offices. They can get the ball rolling on getting the equipment out and authorization from the clinic. So in the home, we can prescribe ventilation, insufflation, exsufflation, which pretty much everybody knows as cough assist. A lot of people equate the name cough assist to any device that will do the cough therapy, but essentially it's an insufflation, exsufflation device. And cough assist is really a branded term by Respironics, but it seems to work and makes a lot of sense that people use it. And we'll go into that a little bit more in detail. We can do suction therapy, we can do nebulization, and we can also do oxygen. So with the oxygen, I put a little footnote there because we don't really prescribe oxygen for our patients unless it's contraindicated. It's contraindicated for a patient unless indicated with a comorbidity. So if they have like COPD and ALS, okay, well now we're kind of treating both things here. So oxygenation with ventilation is good for our patients, but oxygenation without ventilation, where that would be just be like a nasal pain that goes in the nose, could be deadly for our patients. And that's neuromuscular neuropathy. That would be muscular dystrophy, multiple sclerosis, ALS patients. A lot of times, just to kind of go on the side here, a lot of times people will panic in situations and then they'll call, 911, EMS gets there. And the first thing they'll do is they'll put oxygen on the patient's nose with a nasal cannula at like 15 liters because they see the oxygen dip down to like 88, 87. But what they really don't know what they're doing is they're building up carbon dioxide because they're turning the to breathe off. So that's why our patients run into a big problem if there's not the right therapy implemented at the time of that emergency. So going forward, ventilators available in the home. So there's quite a bit of ventilators on the market. The ones that we mostly work with at Millennium are the Astral ventilator, the Brios ventilator, the LTV 1150, which a lot of people have seen. It's been on the market for a long time. And now the new and upcoming one, this multi-function device is the Boxing. So with the Astral, the advantages are that it's lightweight, portable, easy to use. It's got a lot of internal battery in this little machine, and it works great. You could actually extend it out with smaller little external batteries that'll bring out to 16 to 24 hours. The Brios is another one that's, again, lightweight, portable, very compact, simple to use with an active circuit. And I'll go into the active circuit part of that later on. The LTV 1150, it's used for a long time. It's used in the hospitals for portability, and it's used in the home for home care. It's portable, very dependable, and very easy to use. It's probably one of the easiest ventilators to use from a caregiver's standpoint. The Boxing has a lot of advantages. It's portable, multifunction. It's got the vent, cough, suction, nebulizer, and it's oxygen built in. It's got a little sieve built in up top on the machine, and that could provide oxygen continuously throughout therapy up to 5 minutes. And it's also got a very good battery life built in. It's got 2 little side batteries that are on the side that clip in and out. And with all that together, you get about 16 hours. These are some nice pictures I pulled off the internet. So just going from left and right, you can see Astral, Brios, LTV, and the VOCSN, the Boxing. And now getting to the insufflation, exsufflation question. So to kind of get back into what I was talking about before, the first generation cough assist, quote unquote, the device was from Respironics. It's the CA3000. If anybody's ever seen these things, they're like huge tanks. They're very, very big. They're really dependable. We've had them for a long time at Millennium. We still have a lot of them in the field, and people they really, really rely on this machine to help them out. Then the second gen would be the 270 cough assist. Now, this is more of what people have seen on the market as far as like compact. It sits right on the tabletop. It's easy to use. It's got an oscillation therapy, which will kind of like almost vibrate the lungs on insufflation and exsufflation therapy, and it's quite effective at getting to the far reaches of the lungs, the distal parts of the lungs, and it's got a really easy interface to as well. And it's got a built-in battery. I don't know if I put that down there, but it's not a built-in battery. It's got a supplemental battery that goes in the back, which the CA3000 doesn't. So in the second gen cough assist, they put in the battery, and you can actually take it like on the road without having to plug it in. The Byway, this is kind of a newer cough machine. You might see it a lot, not in the home a lot. It's got this PEEP therapy that it uses, and essentially in between the insufflation and exsufflation parts of the therapy, it'll kind of hold the PEEP, which can be quite effective for trachea in particular. And it'll hold the pressure at like 5, 6, whatever it is that you set it up with, and you can go from there and use it quite effectively. They're lightweight and they are they oscillate as well. They have a built-in battery, which is not like the T70, because the T70 will come out and you can put it back in. The actual Byway is one that's built right into the machine, which is kind of nice. And then getting to the Doxin, it's a multifunction device, so it has a cough therapy right built into it. It does a breath sync, which is kind of nice. If you have a patient who's using this machine with a full face mask, right as the breath is going with the ventilation, you can hit the cough therapy option, and it'll actually sync it right into the breath, and then go into the insufflation exsufflation therapy. And then there's, and I'll talk about this a little bit more, there's actually a built-in sputum device into the circuit. So anything that comes out with the patient, you can just turn the suction machine on, it will fall right into that trap. That can be quite effective, so you don't have to break the circuit with the patient. You keep the mask right on. And here are the pictures. Again, going from left to right, you see it 3000, you see it 70, the Byways, and the boxing. Now, suction machine. The boxing, again, the multifunction part of it, it has the suction part, suction therapy on it. You can use it with the travel part, which is, you can see from the bottom to the left, it's got a little travel canister on it. And then essentially what happens is to put it on stationary home mode, quote unquote, you can put a little adapter on there and it'll swing down to an actual canister at the bottom of the stand. And then you can just use it in that mode as well, so you don't have to keep using that travel part. And that's quite effective as well. The PM60 is a stationary device to use, very dependable. It's actually got suction cups and threads at the bottom, so it's quite sturdy too when you put it on like a tabletop or something. And that's a little bit more powerful than what we talked about next, which is the Builder's suction machine. And the Builder's suction machine is a good machine to have because it's got an internal battery on it. It's lightweight. It's easy to use if you're on the go. You're going to your doctor's visits or you're going to clinic. You can bring that machine with you, and it's quite effective at usually for the suction out the your mouth in particularly, but can be quite effective to go a little bit deeper to tolerate it, to get that secretion that kind of sits in the back of the throat for a lot of our bulbar patients. Nebulizers, again, the Voxen's got built into it, goes right into the circuit, so you could actually put the suction, nebulizer, cough, and the ventilation and the oxygen all through a patient, and using it non-invasively or invasively. You could essentially have everything set up right on circuit, so you don't even have to break the circuit at all, and you could run therapy 24/7 like that. The nebulizer is quite effective, and it's got a timer built into it, which I really like. And you could do a therapy for like 20 minutes, and then then the therapy is usually done by the solution is usually done, whatever your nebulizer, whatever medicine you're nebulizer. The BIOS there's no built-in battery into it. It's lightweight and portable. You can plug it in anywhere and use it. So that can be quite effective as well. For quite a bit of our patients have those. Okay. Other equipment that's in the home. So this is going to focus on invasive and non-invasive patients. this will be the 50 psi compressors. So available for tray collar. If you're just sitting at home and you're using this device, you could add humidification to trach therapy. If you're just sitting around and then leave the oxygen rolled into that, if you need it, or if you don't need it, then you can kind of just, use it for that upper humidification. They do make little thermal vents, which are like little sponges that can go on the end of tracheostomies, and that could provide humidity on the go for, if you're going to clinic or whatever, you can't really bring that compressor with you, so you just use the little sponge adapters called the thermal vent. Pulse oximeters, there's a whole bunch of pulse oximeters on the market. We use Melcor. I like the Melcor best. It's a huge interface, easy to see. It's a good pulse oximeter, but there's a ton of them out there. Everybody's pretty much familiar with portable ones. You can put on the finger, and you go to the doctor, and those things are great to have for backups. A lot of my patients, I'll tell them to use them for backups as well. Oxygen concentrators, if so needed. There's 10 liter, 5 liter units available in the home. There's also a home fill system that's available for the home. And they're refillable by what we call deep tanks. And they kind of sit on top of this home fill system. So as the patient's using the therapy, even through the back of the machine or whatever, they can also home fill their tanks. So when they go portable, they can use those portable tanks in the devices to use them, and then obviously you can't take it home. And then when they come back, if it's empty or whatever, they can put the tank right back on and then refill it while they're using it for depending on e-tanks. A lot of people are familiar with those. Those are the bigger ones used in the transport in the hospitals, or the rescue squads are using a lot. There's M60s, which are backup tanks, which we put into people's homes. If we put concentrators in somebody's home because they prescribed oxygen, it's prudent to put a separate tank in the home in case the power goes out. They still have access to oxygen. Based on your leaders, give us a call. We come out and get them situated. The Voxin, like I said before, has a built-in SID bed into it. After this Voxin, that's a power leader. Okay, therapeutic application.
AJ, I'm gonna interrupt you real quick again. I'm sorry. I know you're sitting closer, but it's a little muffled, so I don't know if you can get.
I'm sorry.
Thank
Can
you.
you hear a little bit better now?
Seems better. Yes, thanks.
Okay. All right. I'll try to escalate my voice a little bit. Getting to the ventilation part of it, like why do we do these therapies, and what more specifically are they? How are they helping our patients? So it's with ventilation, it's, like I said before, it's beneficial to normalize saturation of carbon dioxide in the blood while sleeping and as needed during the day. So a lot of this care is prescribed for people while they're sleeping off the bat, right when they get out of, being first prescribed this therapy. It's normally done for basically for a sleeping, type therapy, but it could be quite effective during the day as well. So we can use mouthpiece ventilation for our patients, and we can use those on what we call active circuits. And those active circuits are quite effective at not using what a lot of people will use, which is passive circuits. There's a built-in peak therapy, which is peak and expiratory pressure. For our patients, it would, for non-invasive treatment, would not be as effective for them to use with a passive circuit versus using with an active circuit, because peak therapy is really prescribed for patients who have underlying lung disorders, like COPD. And so we find it more effective for them to kind of just get a deep breath and then really just passively exhale, and naturally, like they would if they were, breathing without any assistance. So we use that with a mouthpiece during the day, and we can use that with an interface at night, like a nasal interface or like a full face mask, or whatever they can get used to and acclimated to. With certain part of the patient population, specifically bulbar, they'll have weaker mouth muscles, so they really can't hold the air in with a nasal interface, so they really have to use a full face mask of sorts. They can go over the nose and around the mouth, or they can go under the nose and around the mouth. So there is different type of masks we can use to help patients get acclimated to therapy. Humidification with the ventilation would be either the HME, which is the heat and moisture exchanger. It's kind of like just a sponge. So the air gets delivered to the patient. The patient will breathe back through the mask. That warm air from their body will reach the sponge and it'll heat it up. So when the next breath comes, it'll be humidified when it goes to the patient. So that's more of like a portability type therapy. Patients were on the go and they were using their machines. Humidifiers can be like tabletop or heated surface. So there's a couple different humidifiers we can use that we could just put a humidifier in, set it for whatever we think would work for the patient, and then they usually go on their way and they'll be fine. Sometimes you have to put a heated circuit in so you don't get a lot of moisture built into the circuit. So you could possibly see either one of those with a patient. But normally it's just a little canister that sits to the side, the tubing goes to it, and then to the patient, from the machine to the patient, to the humidifier, and then to the patient. And then that just kind of takes the edge off of the dry air and it makes it more comfortable for therapy. The insufflation, exsufflation therapy is beneficial for preventing aspiration pneumonia and hyperinflation therapy. So if mucus gets into the airway, it would be advantageous for patients to use the cough assist or any types of insufflation, exsufflation devices to remove that mucus. It's quite effective and it'll prevent pneumonia. So that could be it could be mucus, it could be water, it could be juice, it could be any kind of liquid. It could also be any type of food, company food, or whatever they're having a problem with. Just kind of keeps the airways clean and clear of any type of obstruction. The other benefit to using the exsufflation, insufflation, exsufflation devices is the hyperinflation therapy. So essentially, if people are going to hypoventilate throughout the day and then the weeks and the months, they'll essentially won't be ventilating to their full potential, which would be based on their predicted, which we talked about earlier, or which I talked about earlier, their predicted vital capacity. So, or where they kind of should be is what I said. So there's going to be a thin area around where they should be and where they can only get to because the muscles are weak. And what we want to do is do some lung recruitment. And we want to kind of open up and reverse that atelectasis or those condensed parts of the lungs. And the cough assists or the insufflation, exsufflation devices could be quite effective at doing that with the proper setting. So we would use that with the mouthpiece, or we could use that with the full face mask. Let's go forward here. The nebulizer beneficial for dilating airways. Quite effective for people with asthma. It could help alleviate some stridor with our patients for the effects of turbulent airflow. So that could be beneficial. And oxygen is obviously beneficial for normalizing saturation with ventilation specifically for our patients. Okay, so patient safety in the home. So with our equipment, we want to make sure that all the electrical outlets are grounded. We also want to make sure there's smoke and carbon monoxide detectors and that they're properly functioning. It's important to not have any smoking materials in and around the patient in the house. And if we tell our patients or our caregivers we need to smoke, do it outside. Don't do it around any of the patient or any of the equipment. The area should be clear as possible to perform patient care. Electrical companies should be notified of life-saving pieces of equipment in the home. So that would be the local electric company. And then the local fire company, if you're using oxygen in the home, they should be notified that there's oxygen in the home. All respiratory equipment should have sufficient circulating air around it to keep the machine usable and breathing properly and cooling during operation. Alarms. So with the ventilators, there's a high pressure alarm and a low pressure alarm. And we want to make sure that the alarms are titrated adequately for the patient for the caregivers and as well, to know if there's, the mask comes off or the tubing comes off. So the low pressure alarm would be the most important of those two. And then the high pressure alarm would pick if there was like secretions in the airway or some type of blockage. But basically the low pressure alarm, that's one of the more important ones. There's also a minute volume alarm, which would indicate if you set the alarm, if you set the parameter and the therapy doesn't hit the minute ventilation, it usually means there's a leak, and then that could also be effective as well. There's built-in circuit disconnect alarm, so if the circuit becomes disconnected for whatever reason while the patient's using it, it'll notify the caregivers, and that could be a little bit more sensitive than the low pressure alarm. So that would be effective, especially if they're using the equipment at night. You'd want to know, okay, the mask came off or the tubing came off or something like that. There's a low battery and degraded battery alarms in the equipment as well for the ventilators. And, that could be addressed either with maintenance or switching out the equipment. And then, moving into pulse oximeters, there's high and low alarms for that, for the heart rate and for the oxygen. So if the oxygen dips to like 88 during the night, okay, something's going on. Maybe the high pressure alarm kicking. Okay, I got secretions in the airway. That could be effective at, using the insufflation exhalation devices, whether in the boxes, filter you're using the right on spot, or you're going to grab the 270 and kind of clear the airway. So you can normalize the saturation and clear the obstruction, whatever it is. Equipment maintenance for our ventilators is done every 2 years, most of them. And we send those either back to the manufacturer or we'll do them in-house. And we'll put the same type of equipment back into the home and then take that one out that's due for maintenance and then send it back to the company or do it in our environment department to maintain it. When we go to our patient visits, or we tell our caregivers, we instruct them, keep the equipment clean. It can get a little dirty in the home, so wiping it with any type of non-abrasive solution would definitely clear it up and keep it nice and clean, which is easier to use or it's easy for using the equipment, which is easier. We could replace the cleaning of the filters on the equipment. So a lot of our air inflow filters can be taken out, like kind of washed in the sink a little bit, and then put back in. There are particulate filters which do need to be switched out on a regular basis, whether it's once a month or once every 3 months, whatever the manufacturer protocol is. So those you don't want to put water on, you just kind of want to throw them out and put them on a new one on. With Millennium, our protocol is monthly replacements of supplies. I think that would be good for a lot of DME companies to follow. And that would be tubing, that could otherwise be soiled, for the ventilator suctions, supplies, nebulizer, cough therapy supplies as well. These things just get beat up and used, and they really need to be properly changed on a regular basis. With the ventilator, there's I wasn't quite sure where to kind of sneak this in, so I kind of just put it at the back of the equipment maintenance, because every time we change the tubing on our equipment, we will do what they call a leak test, which is to essentially make sure that the tubing compliance is adequate for the ventilator, and it knows exactly what the what the usability is of the tubing. So we run that every time we change the tubing for the equipment, and that makes it perform at its peak performance. Again, with Millennium, we do monthly visits, and we ensure that the equipment's working properly. We'll order supplies, we'll do cleaning maintenance if need be, and we'll update contact information and emergency contact person. So when we go into patients' homes, our big thing is we want to instruct caregivers on how to properly take care of, their loved ones. We know that they are the first ones in the line of defense in case something happens. So education and re-education is our first and foremost concern. And if that takes one visit, great. If it takes 2 visits, which usually does, 2 to 3 visits, and it's a lot of information. So, but we want to make sure that, the family members and the friends and the caregivers, they understand totally how to work and operate and help the patients in need of the therapies. So we always make sure that we do that. And it's with what I've noticed throughout my experience is that caregivers in the home, a lot of them come and go. So it's important to teach family members in particular and those more stable caregivers on how to do these therapies, so they can educate people who come into the home as well. And so we want to make sure again that we emphasize that. And right now, that was my last slide. Sharice, how am I doing on time?
We can move to Q&A now if you want to stop sharing.
Sure. Get my mouse in. How's that?
Perfect. We do have a few questions.
Okay.
Let me go to the Q&A. Okay. When one is vent dependent, should we have a second ventilator available in case the first one fails?
Great question. Yes, if patients are using the ventilators in the home, especially 24 hours, for sure, we want to make sure that we work with the insurance companies and the prescribing physicians to, adequately and for patient safety, make sure that we have that equipment in the home. But yes, in those cases, we will supply backup ventilation, and to a lesser extent, maybe a backup suction stream or a backup cough assist device or insufflation exercise device. We want to make sure that the patient's taken care of. Yeah.
Thank you.
Yeah.
Let's see. We have heard that if we enroll in hospice, we would need to give up our Voxen machine for another one that hospice covers. Do you know which ventilators hospice would provide?
Okay, so I don't like to speak on behalf of hospice or any other company, especially if I don't know what it is. But I can tell you that when people switch into hospice, that I found through my experience, it would be prudent for a company that's been in the environment for that extended period of time already established, that they should try to work with hospice companies, because that's familiarity to the patient, and I think it'd be prudent for the patient to have that continued care going forward.
You? Let's see. How does one reduce the number of circuit changes? Right now, we use a Voxen passive circuit, but use only circuits for cough assist, one for nebulizer and one for daily use.
So you can actually put a what we call a viral filter, which is or a bacterial filter, which could be effective. You can actually put it at the end of the circuit with a little either pre-cut, which is essentially just a small piece of tubing, and then you can put the insufflation exsufflation interface on that, whether it's a mouthpiece or a mask, and you can actually use the cough therapy without having to soil the tubing. Because it sounds like your question is getting to the point of, well, what if mucus goes down the tubing while I'm using the cough therapy and not soil the tubing? So yes, there are filters that you can put at the end of the tubing that can block that and go from there.
Thanks.
Yeah.
Can someone with a, I'm going to read this. Can a tracheostomy be done? Oh, okay. If someone has a tracheostomy and is on a ventilator, do they need 24-hour, 7-day care? Can a family member care for them without having a nurse do it in the home?
Absolutely. I have many patients, and their family members tend to be really good caretakers. There's a lot at stake, obviously. It's their loved one. Yes, they could be properly trained, and they could definitely manage their respiratory care, for sure.
This is a question about secretions. Would you happen to know how they could be managed?
So with the equipment that we have on the market, of the devices that I talked about earlier, we could do oral care. We could use, which I didn't mention before, I should have, toothaches, right? We can do oral care. We can do brush your tooth. They do make stuff that's on the market that you can use that can be quite effective. They're called toothaches. You can actually look them up online. And we could actually do, if it's tolerable, some deep suctioning through the mouth with our suction devices. It's kind of hit or miss, but basically that secretion management, that's from the respiratory standpoint. Now there are other medications and stuff you can use. You can talk to the doctors about. I know some palpable patches kind of work. They can Botox. Again, I'm not a doctor, but you can definitely address that with your physician.
Thank you. Insurance. Does insurance cover the ventilators?
I hate talking about insurance. I'm strictly clinical, but the DME companies will be able to guide you through all that, especially when you're working for backup equipment. Right? Insurances want to be able to justify, spending the money for what the services are, and we know they're needed for sure. But they need that documentation from the physician, and yeah.
Thank you.
All insurance.
Yeah, it's complicated.
Yeah.
Let's see. How do you get evaluated for best equipment in the home and begin the process with a respiratory practitioner?
Okay.
I'm assuming respiratory therapist, this person means.
Right. So essentially, how does it happen from the clinic to the home? So that was in the earlier part of my discussion. So or presentation. So basically, we would make an evaluation with the patients at the clinic, and based on their numbers and what they need as they present to me as a clinician, I would make a recommendation to the physician, and then the physician would prescribe the equipment along with their physician notes, give them to the DME companies, and they would go for offer insurance, and then if everything's approved and ready to go, we would roll out to the patient's home.
Thank you. I don't think there's any more questions, actually, AJ. I do want to thank you for taking time today, and I appreciate you being here. I want to thank everyone for joining, and please join us for the next session on wheelchair assessments. And thanks everybody for coming today.
Thank you.